Thank you, Marco. Thank you, Jean-Philippe. First of all, I would like to congratulate you really for this incredible leadership and incredible work. So you have seen this central illustration. I'm sure you spent hours and hours on it, just amazing. It was a pleasure working with you. So the topic is on stable coronary disease, and actually is P2Y12 inhibitors selection for PCI in stable coronary disease. We can easily say that clopidogrel, also in the new document, remains the default P2Y12 inhibitor, but the door is now open for more potent agent in selected cases. And the phrasing of the consensus document is that ticagrelor or prasugrel on top of aspirin may be considered instead of stable CAD, of clopidogrel in stable CAD patient undergoing PCI. Importantly, this has to take into account the ischemic and bleeding risk according to different score. You see that the level of the recommendation remains weak with the 2BC recommendation. So routine is clopidogrel the drug of choice. With respect to timing, again, commonly the P2Y12 inhibitor starting is at the time of PCI, but again, pretreatment may be possible in selected cases. And the recommendation is once again a 2BC, so quite a weak recommendation, but in patients with stable CAD, pretreatment with clopidogrel may be considered if the probability of PCI is high. We obviously want to reduce the ischemic risk, but we also want to minimize bleeding, and obviously we are getting more and more conscious about the implication of bleeding. This consensus document gives clearly a class 1A indication, similar as what was done in 2015 non-STEMI guidelines, for the radial approach over the femoral one, if performed by an expert radial operator. Importantly, due to the deceiving result of multiple trials, routine platelet function testing to adjust antiplatelet therapy before an elective testing is not recommended. And Jean-Philippe, who is our chairman, really contributed in a great amount to those data. So with respect to DAPT duration in patients with stable CAD treated with PCI, as mentioned by Hector, we are now moving away from this DAPT for device, meaning stent thrombosis prevention, going to a DAPT for the patient in terms of event recurrence reduction. We may remember 11 years ago here in Barcelona, there's been a big storm of the stent thrombosis issue following the first analysis of the CIPHER stents data. Now stents are better, so we can reduce the duration of dual antiplatelet therapy for what it means, stent thrombosis prevention. On the other hand, we have now means to reduce ischemic events coming later and not related to the stent. So on one, we can go in one direction, but also we may go in the other direction. So with respect to the duration of dual antiplatelet therapy in stable CAD patient, the standard is 6 months, irrespective of stent type. So for the first time, we say that it doesn't matter if you have a bare metal stent or drug-eluting stent, 6 months is the treatment. And we will see that we will not recommend bare metal stent anymore. So the bare metal stent are out. For drug-eluting stent is 6 months. But we may even get shorter, namely in patients considered high bleeding risk, for example, with a precise DAPT score of 25 or more, we open the door for 3 months dual antiplatelet therapy. This should be considered, and is based on 2 studies which has randomized 3 months versus 12 months dual antiplatelet therapy and showed no difference between the 2 regimens. Importantly, these trials use a stent, the zotarolimus eluting stent Endeavor, which is no more on the market. So, but we could go even shorter than 3 months, obviously for patients that are so high bleeding risk in whom we cannot consider or do not want to consider a 3 months dual antiplatelet therapy. For those patients, The degree of recommendation 1 month is weaker, is a 2B, and this is based on 2 different studies, the Zeus studies and also the Leaders Free study. The first one with the Endeavor stent is no more on the market. The second one with the drug-coated stent, BioFreedom, showing superiority of the drug-coated or eluting stent over the bare metal stent despite the short duration of dual antiplatelet therapy. Again, it is unclear whether this evidence can be applied to all drug-eluting stents of the later generation. On the other hand, we may go longer than 6 months, and we may even go to 30 months for patients considered to be at high ischemic risk, but at the same time at low bleeding risk. So for those patients, we have an option. It's important that parameters for high risk of stent-driven recurrent ischemic events have been identified and they are listed here on the slide. And also, different duration of dual antiplatelet therapy have been related to the degree of complexity of the procedure. And indeed, there is a meta-analysis, a patient-level meta-analysis from 6 randomized trials investigated DAPT duration after PCI of approximately 10,000 patients. And in this meta-analysis, complex PCI was defined as one of the following characteristics: either the 3 vessels treated by PCI, more or equal than 3 stents, more or equal than 3 lesions, bifurcation with 2 lesions, total stent length greater than 60 millimeter, or chronic total occlusion. You see, these are the same parameter I was showing you in the previous slide. I want to show you where the evidence comes from. And in this meta-analysis, the investigator looked at long, greater than 12 months, versus short, less than 6 months, dual antiplatelet therapy on MACE and major bleeding. What you see from this slide is obviously that patients with complex PCI have more events than non-complex PCI. This is quite easy. On the contrary, they do not have more bleeding. But what is important is that there is a reduction which is significant with prolonged dual antiplatelet therapy, with longer dual antiplatelet therapy in patients with complex PCI, while this is not observed in patients with non-complex PCI. And the interaction is significant. So there is a correlation between the degree of complexity and the benefit derived from prolonged dual antiplatelet therapy. On the contrary, there is no increased bleeding according to the complexity of the procedure. One word about bioresorbable scaffold. So what I told you before is just for metallic stent, is not for bioresorbable scaffold. For those devices, the task force believe, and this is a common level of evidence C, is a consensus, that in patients with stable CAD treated with bioresorbable scaffolds, dual antiplatelet therapy for at least 12 months should be considered. There is no evidence on what is the optimal duration of therapy in patients undergoing bioresorbable scaffold PCI because this has never been investigated. Nevertheless, there is more and more evidence that those devices have an increased stent thrombosis risk compared to their later generation drug-eluting stent. I'm showing just a piece of data here with an odd ratio of 3 for definite of probable device thrombosis in disfavor of bioresorbable scaffold compared to the everolimus eluting stent in almost 6,000 patients published in The Lancet very recently. So drug-coated balloon, niche procedure, very little data. The recommendation is to give dual antiplatelet therapy for 6 months, knowing that the studies are very limited, no randomized controlled trial in this field. So this is a summary algorithm for the duration of dual antiplatelet therapy for stable patients. And as previously mentioned by Hector, there is no more difference whether now you have a drug-eluting stent or you have a bare metal stent. With both, you have to assess the bleeding risk. If the patient is low bleeding risk, then you give for 6 months. And the recommendation is to use drug-eluting stent in all the patients, even in patients at high bleeding risk. Then you may continue to be indication beyond 6 months with the patient and increase ischemic risk. For example, patient with complex PCI as previously defined. If the patient is high bleeding risk, then we have two options. Either the 3 months dual antiplatelet therapy, this is a class 2A, or weaker indication for patients believed to be at very high risk of bleeding, 1 month of dual antiplatelet therapy. Again, even in patients with very high risk of bleeding, no bare metal stent, but just drug-eluting stent is recommended. With bioresorbable scaffold, as I mentioned, 12 at least months dual antiplatelet therapy is believed to be the treatment of choice in the absence of definite data. Gender consideration and spatial population, the consensus is that the benefit of dual antiplatelet therapy is the same among female and male, and so the type and duration of dual antiplatelet therapy is recommended to be exactly the same. With respect to diabetes mellitus, also the duration of treatment should be the same among diabetic and non-diabetic patients, and I will show you that in patients with lower extremity disease may be considered a dual antiplatelet therapy beyond 12 months. And I'm showing you now the data for these three groups. So here, with respect to gender, and respect to short versus long DAPT duration following PCI, you see that there is, in terms of males, there is no difference between female and male, and the same is true for bleeding. So no reason to treat women differently than men with respect to the duration of dual antiplatelet therapy. With respect to diabetes status, I'm showing just one piece of evidence, but overall, the benefit of antiplatelet treatment is the same, and so there is no reason to treat diabetic patients differently. These are data from the Pegasus study, and here you see that in green light, these are the placebo patient, and in violet light, these are the ticagrelor patient, independently whether you are diabetic or non-diabetic, the relative risk reduction is exactly the same, 16%. Obviously, the absolute risk reduction is a little bit higher with the diabetic patient because the event rate is higher. So overall, the same benefit. With respect to PAD patient, there is an analysis of the Pegasus study showing that PAD patients not unexpectedly have high event rates, but at the same time derive also a good benefit of ticagrelor, prolonged ticagrelor treatment, although there was no statistical significant interaction documenting that there was a preferential benefit. Nevertheless, the high event rates in the PAD population and the nice reduction in terms of absolute risk reduction of 4% justified, in our opinion, a weak indication for prolonged dual antiplatelet therapy in patients with lower extremity arterial disease, again, class 2B indication. So my take-home message, ladies and gentlemen, dear chairs, with respect to DAPT in stable patients with coronary disease undergoing PCI, we went away from a pure stent thrombosis prevention scheme to a more global reduction of ischemic events. Clopidogrel remained the default P2Y12 inhibitor in patients with stable CAD treated with PCI, irrespective of the type of metallic stent implanted, namely BMS or drug-eluting stent. The duration of DAPT is 1 to 6 months, for the majority 6 months, depending on the bleeding risk. For patients in whom the ischemic risk prevails over the risk of bleeding, a longer than 6 months dual antiplatelet therapy duration may be considered. Similar type and duration of DAPT are recommended in males and female patients, as well as in patients with and without diabetes mellitus. Prolonged dual antiplatelet therapy regimen may also be considered in patients with lower extremity arterial disease or who have undergone complex PCI. And if you want to know more, in addition to the guidelines, I invite you to see this document that was also published online. Is a companion paper of the dual antiplatelet therapy document looking into cases and how the task force member suggests the treatment in very specific situations. Just to give you the flair, one case with respect to stable CAD is an elderly patient, multi-vessel disease treated with PCI. The second one is epistaxis and dual antiplatelet therapy, very late-stage thrombosis, what to do following bioresorbable stent or biodegradable polymer resoluting stent. Dual antiplatelet therapy, risk scores, platelet reactivity, bioresorbable scaffold, all these issues that you may encounter in your daily practice are to be seen there. And I thank you for your attention.